Thanks everyone so much for joining us for the launch of our report on the case for investing in NHS staff wellbeing. This was commissioned for the University of East Anglia and RAND Europe by the International Public Policy Observatory, which is hosted at University College London and funded by the Economic Social Research Council. You can follow us on Twitter at COVID and Society, and if you want to get involved in the conversation, please use the hashtag NHS Wellbeing. Again, thanks so much for joining us today. I'd like to start by passing over to two frontline healthcare professionals who will help set the scene for us. Please welcome Dr. Kevin Fong, Professor of Public Engagement and Innovation at the Department for Science, Technology, Engineering and Public Policy, and consultant anaesthetist at UCLH, and Sandra Barrington, matron of a critical care unit at the University Hospital of the North Midlands. Thanks very much.
Thank you, Aidan. So I'm going to start off here before handing over to Sandra. So as you heard, I'm Kevin Fong. I worked in intensive care units during COVID-19. I transferred patients between hospitals. I saw hospitals all over the country. I think for me, this report is going to be important because we've tried to keep it as close to the front line and the impacts on the front line as possible. I'm here to tell you that we're in trouble. There's no way of sugarcoating that. We have huge rate of reported mental health disorder amongst our frontline staff, rates of post-traumatic stress estimated to be in excess of that seen in British military veterans who served in the Afghan war in the wake of the most recent COVID surges. Now, the workforce is in crisis, and that crisis of well-being threatens the safety and quality of patient care on a daily basis. COVID has exacerbated the picture, but the problem with poor health and well-being amongst our staff predates the pandemic. We've arrived at the end of a decade which, according to the King's Fund, has been the toughest financial settlement in the history of the service. We started the pandemic with more than 100,000 vacancies across the NHS. And according to the most recent survey, NHS staff survey, 47% of our staff report feeling unwell because of work-related stress. Other surveys show evidence of exhaustion, burnout, and far worse. And so this is a time for action. We can't ignore this. This is a real problem. The problem, I think, here is that even before COVID, we had adopted a strategy in a resource-constrained environment of stretching the staff increasingly into the gap between demand for healthcare and provision of human resource. And that came at a cost, and the cost was paid for by the staff. And so as we go forwards then, we need to think about how we can best address their well-being. The NHS is the people who work within it and the care that they deliver. The evidence you're about to hear shows you a few things. First, it shows you that our previous approach, whereby in a resource-constrained environment, we choose between investing in patient care and investing in the staff, it casts that as a false choice in a false economy. The needs of the patients and the needs of the staff who care for them are aligned. If you invest in the workforce, you are investing in patient care. So that's a very big change. The second thing is that prevention here, as everywhere, is better than cure. And the well-being of our staff is woven into the fabric of our buildings, the structure of our rotas, and the conditions of our daily working lives. And so the change will not be easy. It won't be easy, and it won't be cheap. But what this evidence review shows is that actually this is investment and not expenditure, that there are vast savings to be gained if we can just even slightly erode the negative impact to staff absences, presenteeism, and ill health amongst our staff. And so I think this is the time for action. If there's one good thing that comes out of COVID, it is that it has illuminated a problem that has been long-standing, and it illuminates it properly for the first time. There is, again, no way to sugarcoat this. The NHS is in crisis, the workforce is in crisis. COVID hit us hard, harder than I can begin to describe for you here. If we've talked previously in other corners about needing to recover the workforce before we recover the health service, actually it's more urgent than that. We need to recover the workforce so that we are able to recover the service. We cannot meet the challenges that face the NHS in the immediate and medium term, or indeed prepare us for what lies in the future, if we do not make these changes. So I think the time for action is now. I think the time, the urgency is enormous, and we need to be a service now that does what previous reviews have told us to do, which is puts the health and well-being of the workforce at the center of what we do organizationally and operationally, and doesn't see that as a priority that is a nice to have or as a secondary priority. It is the only priority at this time. Thank you very much. I'm going to hand over to Sandra now, and Sandra and I work closely together during COVID-19. We together saw a number of units, and Sandra herself worked at a very busy intensive care unit, running a very busy intensive care unit in Stoke. So Sandra, thank you.
Thank you. So as Kevin says, my name's Sandra and I'm the matron on a critical care unit at the University Hospital of North Midlands. We're a major trauma centre and have a 52-bedded intensive care unit. I've been asked to talk to you today about my experience at the front line during the pandemic and how it's affected staff and the impact on our service. And I've included some feedback they obtained from other units when I visited them as part of an InReach team led by Professor Fong. So in response to the pandemic, critical care units throughout the country were asked to come up with a plan to deal with the increase in demand for critical care beds. And we came up with a plan on paper to take 180 patients and prepared as much as we could. Staff were deployed to us from elsewhere in the trust to support us. And the teams at this time were positive, motivated and focused on meeting the challenges ahead, whatever they look like. We were fortunate at that time that we had a fully established, stable and experienced workforce, and support from the public at this time was also immense and a boost to staff. However, nobody imagined the pandemic would continue for such a prolonged period of time, during which we were faced with an increased number of COVID patients being admitted, as well as an increase in other patients, such as trauma, as the lockdown was lifted. But this time it was with little or no help from other areas within the hospital, as deployed staff had returned to their normal roles. At the same time, there was a clear shift in public attitude, which was felt by staff. There was an increase in complaints from relatives, demands for updates and aggressive challenges to medical decisions, as they talked as if they were the COVID experts based on what they'd seen or heard through press, social media and the internet. We'd moved away from a public that would clap the staff each week and welcome and appreciate everything that the staff were doing. This was demoralising for staff who continued to work under such challenging circumstances. ITU staff were faced daily with looking after some of the sickest patients that they'd seen, working in full PPE, long hours, often without proper breaks. They worked extra shifts, but still there weren't enough staff to look after the patients coming through the door. Staff started to become stressed and anxious as they saw more patients, some very young, be admitted and die. They were afraid that they would contract COVID and become a patient themselves, particularly as we did have members of staff on our unit with COVID, some of whom did not survive. And this was the same across the country. And I cannot begin to describe the devastating effect this had on colleagues. The medical team were faced regularly with making really difficult decisions about which patients were stable enough to transfer to another unit to free up capacity for the next unstable patient, and as well as decisions about which patients would possibly benefit from the advanced support we could provide and those that may not. At our peak, we ran out of physical bed spaces, didn't know where we were going to put the next patient, and had to resort to putting 2 patients into 1 bed space. At this time, we ran out of ventilators, pumps, and had to sometimes make decisions about which patients could be taken off a ventilator, for example, for a period of time, or manage a little longer on high flow oxygen without advanced respiratory support. Staff were caring for critically ill patients outside of the critical care unit, and this had the added pressure of not being familiar with the area and where things were, and often felt isolated, vulnerable, and afraid without the support they needed. Patients were dying daily. Bad news was being broken over the phone or via an iPad, and relatives who were unable or afraid to come in when their loved ones were receiving end-of-life care was sometimes asked to be with them virtually in the last moments of life as they passed away. But this was over a phone or an iPad with the nurse at the bedside facilitating it. It was harrowing for the family, but also for the nurse, who was unable to provide any comfort to that relative in the form of a hug or handhold in the way they would do normally. Staff were and still are haunted by the cries of these loved ones. They felt helpless. And this was a common theme from nurses in other ITUs who talked about that feeling of helplessness, as they were not able to give the care they wanted to or felt was required, or couldn't attend to alarms or buzzers as help was needed. Staff told me about flashbacks they had had about the distressed relatives crying over the phone and feeling unable to support them properly. They described awake patients they'd got to know well, being on maximum support, deteriorating despite this. The patient knowing there was nothing else that could be done for them and they were going to die. Watching this patient gradually pass away was awful, and something that the nurses saw a lot of and reported the devastating effect this had on them. It was unlike anything they'd seen before. Staff reported being asked by such patients to tell their loved ones that they loved them and pass on other personal messages or notes after they had died. We were asked to contact solicitors to get wills put in place as they tried to put their affairs in order before they passed away. Staff didn't have any time to process or accept that loss, because as soon as that patient had passed away, there was a demand for the bed for the next critically ill patient, who also sometimes did not survive. Staff worked tirelessly, but as the pandemic continued, they were emotionally and physically exhausted, and some described they had nothing else to give, particularly experienced staff who were also trying to support their inexperienced or broken colleagues. The home circumstances of staff also had an impact. Many were fearful of taking COVID home to their relatives, particularly those with a young family or if they were looking after someone who was elderly or vulnerable. Some have families that didn't want them at home because of the fear they would catch something, and I heard of nurses sleeping on camp beds for weeks on end, away from their family or in temporary accommodation, or having to change on their front doorstep for fear of taking the disease over the threshold. One nurse told me she had a recurring nightmare that she'd contracted COVID and was the dying patient. She had a young family and worried about what would happen to them and which of her relatives would be the one designated visitor allowed to come in at that time, and she'd wake up crying. Others talked of problems sleeping or disturbed sleep patterns. Staff on their days off described being unable to switch off. They knew the pressures their colleagues were under and felt guilty being at home, but also anxious about going in and what it was going to be like. Dealing with what felt like constant death was overwhelming. Staff with children also said that when they needed to be homeschooled, when schools closed down, described feelings of guilt as they felt too exhausted on their days off to do this or even wanting to do it. They described being intolerant and irritable at home. Nearly all staff reported that subsequent waves of COVID after the first were the hardest. The adrenaline and drive had gone and was replaced with exhaustion, fear, anxiety, and stress. My own trust and those I visited were supportive of implementing measures to support the well-being of their staff. They recognised the toll it was taking, but this varied considerably across the country, and staff told me that not everything helped or was appropriate. Initially, staff responded positively to gestures such as free parking, free food and drink, rest facilities, etc. But over time, such things were no longer impactful. What they wanted was to know when it was going to end. When was there going to be normality, not only at work, but at home? When would they be able to provide the high standard of care for their patients rather than trying to look after multiple critically ill patients at the same time, not being able to do it properly? And nobody had the answers to these questions to relieve their stress and anxiety. The experience of staff on intensive care has sometimes been compared to working in a war zone, multiple casualties and death, providing life-saving treatment only, without the right numbers of staff or always the equipment needed. The difference, though, is that nurses in the NHS are not trained to work like this. They come into the profession to make a difference, to be able to provide holistic care with the time to do this properly and with adequate support when needed. I saw a very exhausted, demoralised, tearful and broken workforce in my unit and others across the country, both nursing and medical, and the effect is still evident. The impact on my unit is that we have seen and continue to see high levels of sickness, which impacts the workforce today, and a significant number of experienced ITU nurses that have now left to go to non-acute jobs, ones they think will be less stressful. Some have reduced their hours, and some have actually left the profession altogether. I've received a significant number of requests recently for career breaks as staff take time out to reevaluate what they want to do in the longer term. Currently, I'm unable to staff all of our critical care beds due to vacancies and sickness. And although we continue to try and recruit to our vacancies, it's going to be some time before these staff are in post and have the skills and experience to provide the level of care needed for the critically ill. Many staff who are in work today are yet to rebuild any resilience and remain very fragile. It's essential we recognise the effect that the pandemic has had and continues to have on staff in critical care in terms of their well-being. We now have a depleted workforce in terms of numbers and skill, and staff continue to question whether remaining within the profession is what they want to do. Planning and investment is needed now to ensure that there is an adequate workforce for the future. We need to make sure staff are not only recruited but retained. Staff need to feel valued and supported and invested in through education, training and development, so they have the tools and time to do their jobs properly and can make a difference. Investment in their well-being is essential, as without this, attracting nurses into the profession and keeping them is going to be very difficult. Thank you.
Thanks so much for that, Sandra. Before I hand back to Aidan, I just wanted to say thank you. Sandra and I visited a large number of hospitals across the country. None of them escaped unscathed in this. And as I said before, you know, the well-being issues that we're talking about today predate COVID, but COVID, you know, if there's one advantage in it, is that it usefully illuminates a problem that we've ignored for far too long. The frontline teams need us to help them. They need someone to do something, and all of the challenges we face in the future depend upon us recovering the workforce properly, and that will require ambition and investment at scale. But without it, we will not solve this problem. Thank you.
Thank you very much, Kevin, and thank you, Sandra, for sharing that very deeply personal but harrowing accounts of your experience in this situation. I think this is really important and really timely with the launch of this rapid evidence review, and a good opportunity now for us to pass on to our review team at the University of East Anglia and RAND Europe, who will look to present the rapid evidence review and cost analysis. I'd like to introduce the review team, Kevin Daniels, Professor of Organisational Behaviour at the University of East Anglia, Sarah Connolly, Professor of Personnel Economics at the University of East Anglia, and Dr. Chris van Stolk, Executive Vice President at RAND Europe. Thanks very much.
Morning, everybody. Can everybody see my slides? Are they there? Chris is nodding.
Yeah,
brilliant, thank you. So between the three of us, we're going to highlight the main findings from our report, which is based on a rapid assessment of evidence and cost effectiveness analysis of that evidence as well. So we focused on changes to management practices and how work is organised, scheduled and conducted in the NHS. And there are a number of reasons for that. If you think about it, that's what people experience every day at work. So that's going to be the most profound influence on someone's mental health and well-being in the workplace, because that's what they experience every hour, every minute of their working day. And there are multiple studies, thousands of studies, large-scale studies that indicate how work is managed, organised. So we're talking about levels of skill use, how work is delegated, how managers behave to the people they manage, how co-workers behave with each other. Multiple studies indicate this is important for mental and physical health. And the psychological aspects of work also have an impact on our physical health. I think more importantly, if you look at guidance from various bodies, all of this guidance focuses on one of the things you have to do is make sure your working environment is a good work, a psychologically healthy working environment. And that comes from Steve Borman. I'll be speaking in a minute, but these are recommendations that are in the Borman report from 2009. Also recommendations in the Stevenson Farmer report on mental health at work from a few years ago, which the NHS has accepted those recommendations. NICE, the NHS's own primary advisory body, recommends this as an approach. International standards as well, and critically, it's embedded in the interpretation of psychological health and prevention of problems in the 1974 Health and Safety at Work. We focused on the NHS in particular. There's limited evidence, as we'll see, from the NHS, but the NHS has a number of distinctive contextual features which you all know about. It's highly institutionalised, highly politicised, and resource poor, both in terms of finance and time. So those contextual factors are important to take into account, which is why we didn't try to bring too much evidence in from other areas, only to fill gaps in our interpretation. And as most of you know, rapid evidence assessment, rapid review of the evidence replicates many of the key features of a full-blown systematic review, but we're able to conduct it much more quickly within the scales required by IFA. So what did we find? We didn't find too many studies, that's true. And of those we found, we categorise in the way shown here. So there were 2 studies that looked at systemic cultural change within specific units or trusts or GP practices, which included leadership development in there as well. So you kind of look at large scale changes to how work is organised within particular areas. Both of those studies indicated improvements in well-being for staff, and both of those studies also indicated improvements in performance in relation to safety or patient care. There were 3 studies that focused on more limited changes within specific areas, specific units, focused on specific aspects of the psychosocial work environment, psychological work environment. So these are things like improving levels of people being able to take decisions that influence their day-to-day tasks, trying to limit demands, and so forth. There was only 1 study that indicated any improvements in either performance indicators or well-being, and that was a very, very small scale study with a small short-term follow-up. So we can't conclude too much from that. 2 studies that looked at providing various forms of staff support. So many of you will be familiar with Schwartz rounds. There's also clinical supervision. Again, we saw here that there were improvements in how staff reported their well-being, particularly for staff in need in the Schwartz round. So those with more severe problems, if you like, but no direct evidence of any improvements in performance. Doesn't mean to say that there aren't improvements in performance associated, but what wasn't assessed in these studies. 2 studies looked at changes in the physical work environment. One was focused on basically ergonomic stand desks, which you would think would be focused mainly on musculoskeletal health, but that study, large-scale randomized control trial, indicated improvements in psychological well-being as well as physical health markers. And one that was conducted during the pandemic on the provision of rest spaces for ward staff, which again indicated improvements in well-being and perceptions of support as well. In relation to performance, the desk-related study took multiple measures of different measures of performance. Some of those improved and none of those got worse. So there's kind of limited improvements in performance, but there were improvements in performance there as well. One study looked at automation. This was basically using a robot to do the dispensing in a pharmacy, a hospital pharmacy. And for most staff, there were improvements in wellbeing, which were basically attributed to having the technicians and the pharmacists being able to do more interesting work and patient-facing work and clinical-facing work as well. So for most staff, there were improvements. And there were quite profound improvements in performance, especially around safety, which was directly attributable to using robots to do tasks which require lots and lots of repetitive actions and accuracy as well. And the last study we looked at home working in the pandemic, and this was kind of mixed on performance. I might tell you something about home working going forward. So the nurses in this particular study reported there were some aspects of their work they couldn't do and they found distressing doing virtually, because it was really difficult to do consultations virtually. But other aspects of their work and other aspects of wellbeing, such as work-life balance, improved, and those aspects of work which were conducive to working at home with things like routine admin tasks. So that might tell you something going forward about how more flexible working can be used. So in conclusion, what the evidence indicates is that improvements are possible. There are things that can be done. The evidence base is limited, as in the number of studies. It's also limited in terms of the economic analysis, and Sarah will be coming on to that shortly. And there's very little on actually how to make those changes. So there's indications of what can be done, but very little on how to do it. Also, the studies don't reflect practice. And we're going to come on to this, and Chris will come on to it as well. Because what happens in practice is that organisations, and the NHS is no exception here, will have multiple activities in their wellbeing offerings. So there'll be an employee assistance program, for example. Some organisations, some trusts, some might have sort of health promotion or something like that. So we don't really know how these different activities work and interact alongside other activities, although the guidance is you have to do multiple things as well. A critical thing that's missing, but there is one Australian study that indicates if you increase staff levels, you increase performance and you increase staff wellbeing in hospitals. But we have no evidence from the NHS, direct evidence on what large-scale increases in staffing would do. I think for practice, again, Chris will come on to this, that we are recommending very systemic cultural type changes, which would subsume many of the things that were in our review anyway, such as improvements to the working environment, perhaps some home-based working and so forth. So multiple activities. And certainly what we know from other sectors is that implementation of these kind of practices and these cultural changes is more likely to succeed where there's high levels of persistence and continuity, accompanied by learning, what's called basically continuous improvement. You try and learn from what you're doing and build capability that way, and that learning enables adaptation to specific circumstances. So I'll hand over to Sarah next to go through the economics.
Thanks, Kevin. So if we move on to the next slide. Thank you very much. So Kevin has outlined the evidence on what interventions work within the context of the NHS. And Richie Woodard and I were really looking at how we could start to build a business case for investment in staff health and wellbeing. And we start with really, what's the cost of the status quo? What's the cost of doing nothing? And we find this to be really very sizable indeed. Steve Borman in the report back in 2009 already established the evidence on the cost of days of absence to the NHS. And since then, days of absence, especially those due to poor mental health, have been rising. And as very powerfully mentioned by Kevin and Sandra earlier, really seriously exacerbated through COVID. And so now the costs of absence to the NHS is at about £3.8 billion a year. But in addition to taking time off work due to ill health, many people work while they're ill, and this is known as presenteeism. And Sandra described some of the pressures that people feel to do this. And research has shown that this results in impaired work performance and loss of productivity. And this is estimated to be at least twice the cost of absenteeism. And the NHS staff surveys reveal quite a significant problem of presenteeism in the health service. The most recent staff survey, 54% of respondents answered yes to the question, in the last 3 months, have you worked despite not feeling well enough to fulfill your duties? So there is a significant problem of presenteeism within the NHS, which we estimate to be approximately £6 billion a year. But beyond that, what we also know is that the NHS spends a lot of money on agency staff to cover unfilled vacancies and staff absences. And what we do in the report is to focus on the elements of that expenditure that can be attributed in some way to poor health and well-being. And so we look at the cost of cover for days of absence due to poor mental health, and we look at the cost of cover for those who voluntarily quit the service, and that comes to about £2.2 billion a year. So in total, the cost of poor health and well-being within the NHS, the cost of doing nothing, is already £12.1 billion a year. And so there is certainly scope for doing something and for saving significant amounts of money based on the evidence base that Kevin has just been describing. And we can see that even moderate savings could lead to expansions of thousands of doctors, nurses, or other healthcare professionals. Kevin, if we can move on to the next slide, please. Thanks very much. So while the exact nature of the costs and benefits will depend on the precise intervention, what I'm going to do here is just give you a flavour of the sorts of costs and the sorts of benefits that we have been monetising in our cost effectiveness analysis. Now, the first thing is that whenever any new intervention is implemented, there will be setup costs, there'll be planning costs and awareness raising, ensuring that staff are aware of the support and encouraged to use the support. And obviously, with some of the interventions of the sort that Kevin was describing, whether it's automation, whether it's investment in infrastructure, there will be cost of new equipment, there'll be disposal of redundant equipment, there may be software maintenance costs or license fees, and all of these are taken into account in the costings that are described in detail in the report. Where the interventions are more along the lines of the clinical supervision interventions or the improvements in safety culture or cultural change, well there the costs will really be around staff time, and that's time taken to undertake training or engage in coaching or participating in the intervention. And it's really important to stress that these costs that I'm going to present take account of that time, and taking account of that time, it's not enough to just provide the training option. You've actually got to give staff the time within their workloads to engage in the interventions, because that's key to the success of the intervention. Now, many of these interventions were associated with improvements in mental and physical health, and these improvements led to statistically significant reductions in absenteeism and presenteeism, which will certainly yield financial savings. Kevin's already mentioned that the automation project, the automatic dispensing unit in the pharmacies, saved pharmacy and nursing time. It also made improve patient care in the sense that it led to fewer mistakes, but also freed up time for the pharmacists to engage with their patients more fully, and this led to much stronger senses of job satisfaction. One of the cultural interventions were safety huddles, and these also led to better patient safety. The two cases that we looked at were intended to reduce falls on wards, cardiac arrests on wards, and again, there were statistically significant improvements in patient safety. The automation project also reduced other kinds of costs and reduced wastage of drugs becoming outdated. And the flexible working initiative gave the nurses involved a sense of empowerment, but also there was savings in terms of fewer requests to change or swap shifts and fewer complaints, which can be associated with lower staff turnover. Kevin, if we could move on to the next slide, please. Thank you. So looking at the costing results in detail. The table highlights the costs and the benefits and the rates of return. It indicates whether these are per ward costs and benefits, per participant costs or benefits, or total costs and benefits. And I'm also giving there the details of the study where we extracted these costs and benefit information. Now, most of these studies had relatively short follow-up periods, so I'm thinking 3-6 months, and I think that will lead to an underestimate of the benefits, but if we take these figures on a sort of 3 to 6 month follow-up basis, what we're seeing is a rate of return of around £2 per pound spent. In the case of the automation intervention, 3 automatic dispensing systems invested in a hospital in France, this was a much longer term initiative that was over a 6-year period. And you can see that the costs are significantly larger, but so are the benefits. And here, the return on investment is around 4.38 euros per euro spent. The only initiative where we were unable to detect a positive return in the 3 to 6 months follow-up was in the flexible rostering initiative. And here I think that the issues related in part to the short time frame, but also that the setup costs were significant for the size of unit involved. And there's certainly evidence from Australia that systems like this, or automated workload systems, can be made available across larger numbers of wards, larger numbers of hospitals, and be associated with much greater savings. And certainly in the evidence from Australia and America on similar kinds of schemes, there's evidence that this kind of system is associated with lower staff turnover, greater staff empowerment, and in other sectors outside of health, these kinds of flexible working arrangements are also associated with greater ability to attract certain sorts of staff, certain demographic groups. So that's a whirlwind tour of the cost effectiveness of these interventions, and Chris is now going to talk to some of the implementation issues.
Well, thank you, Sarah, and also many thanks to Sandra as well for her testimony. Sometimes for us in the ivory tower, we look at the data, we look at the evidence base and so on, but it's really important to connect this, as Kevin Fong also mentioned, to frontline staff. So I guess this review does two things. It builds that business case in terms of why investing in health and well-being of staff is important, and also how it pays off in the long run. And this, of course, harks back to the Borman review that was done in 2009, and we'll hear from Steve Borman in a second or two. And the second level is to look at the evidence base of organizational practices, as Kevin Daniels highlighted, and then, of course, their cost effectiveness. So that's what this review does. What it also shows, to some extent, is that there's no silver bullets. I think Kevin started making this point around practice. There's no silver bullet in terms of improving the health and well-being of NHS staff. In fact, the focus on NHS health and well-being and the health and well-being of staff cannot really be an add-on. And ultimately, what we're recommending in this review at a higher level is that what we're looking at is wider organizational change and of course, change in the culture of the NHS in how they deal with their staff and the health and well-being of the staff. So what does this mean in practice? Obviously, that means putting the health and well-being of NHS staff at the core of everything that the NHS does, the core of the operational plans, the governance and strategies. I think Kevin Fong made the argument that there's a strong alignment between the health and well-being of staff and also patient outcomes, but I would argue also quality of care outcomes, financial performance, and a wider range of outcomes. So this is something that is important. It's a very important relationship that we need to support, and that means also that there needs to be a step change in how the NHS operates. And this is broadly similar also to some of the findings of the Messenger review, which you may have seen around leadership in the NHS. So another point in terms of the inspections, so we're not only talking about operational plans, governance and strategies, and reviews by regulators, so whether these are CQC inspections or other sort of reviews by regulators, again, well-being needs to be at the forefront. Often, actually, well-being is sacrificed by some other recommendations in some of these inspections, and that needs to change in the long run as well. If we're thinking about improvements in NHS governance, we need to really think about the accountability that those in the system have for looking after the health and well-being of the NHS workforce, and also the incentives, I think, within that system. And these are really important aspects. So, for instance, one of the changes that NHS England has been involved in is the Wellbeing Guardian program at board level in NHS trusts. I think this is an important step forward, but more can be done around this. And one of the interesting findings I thought from Sarah's and Richie's review around the business case is in fact that one of the things that is particularly costly in terms of poor NHS staff health and well-being is the concept of presenteeism, when people come to work when they're actually not well. And this is something that we actually don't measure at all. We don't really have a particularly good handle on. So there's many aspects around health and well-being of NHS staff that we really do not understand properly. We don't understand the trends in that. And so that also speaks to a more frequent and probably a more operationally focused tool to monitor the health and well-being of staff that go beyond the measurement that takes place in the staff survey. And Kevin, if you could move on to the next slide. An important message also, I think, coming out of the review is spend money to save money. So there is an investment case to be made here. The investment seems logical, but also needs to be sustained and needs to be ring-fenced, cannot be sort of marshaled for other purposes. And what this review shows is that intrinsically, this investment over time will also save money in the system by improving the health and well-being of staff, reducing absenteeism, and also presenteeism, and improving wider organizational outcomes in the NHS. And this goes back to the business case that Steve Borman made in 2009. The money saved that within the system from some of these investments could then be spent on more staff to help reduce the burden of poor mental health in the NHS. And I think Kevin Daniels alluded to some studies in Australia that shows that just the increases in staff numbers in and by itself have positive effects on the overall health and well-being of staff within a health service. And then finally, I guess I'm a researcher at heart and work a lot with researchers. No report and no conclusion would be right without saying that more research is required. We have some understanding of which organizational practices could really have a benefit within the NHS context, but it was really surprising in this review how little evidence that there was in terms of this rapid evidence assessment. So this is also maybe a call to some of the research funders to spend more attention on this particular topic. And Aidan, I'll hand back to you. And Kevin Daniels, you can stop sharing.
Thank you very much, Chris, and thank you very much to the entire review team for that fantastic presentation. Can I just remind everyone, please do pop your questions in the chat if you have them for any of our review speakers, and we'll look to get to those in a Q&A session that we've got coming up shortly. A big welcome to those that have joined throughout the event so far. Just to remind you, this event is being recorded for those that are unable to attend and will be put on our YouTube channel afterwards. If you do want to get involved in the conversation, you can follow us on Twitter at COVID and Society using the hashtag NHS Wellbeing. We're now going to look to hear responses to the report from different perspectives, NHS England, cost analysis. But first, to discuss the business case, I'd really like to introduce Dr. Steve Borman, CBE, Director of Employee Health Consultants at Empactis, and Professor Dame Carol Black, Chair of the British Library, the Centre for Ageing Better, and Think Ahead. Thanks very much.
Aidan, thank you very much indeed, and it's been humbling to hear earlier speakers speak and to share their experiences and to hear the business case re-articulated. I think on behalf of Carol and I, we could just say, we told you so. And going back to 2009, it was very clear that there was a very easy business case for why staff health and wellbeing in the NHS mattered. It does impact on patient care, it does impact on patient outcomes, it does impact on organisational efficiency, and it did impact on achievement of regulatory outcomes. But in the 10 years in the run-up to the pandemic, it's fair to say that the investment case was very difficult to make. And in fact, in many units, there was disinvestment in staff health and wellbeing. And actually, it was very, very difficult to sustain many units in the NHS, which is why it's just humbling to see how well the NHS stepped up at the beginning of the pandemic. And that includes the staff health and wellbeing support units in terms of what they actually managed to achieve in the early days. And that was clearly a huge part of the response. And what was significant was that there was a shift in understanding of what good occupational health and wellbeing is about. It's not about a breakdown service that you get sent to when actually you're underperforming or you're broken. It's about protecting staff in the first place, and it's about preventing illness in the first place. And that's what we saw develop and be very visible during the pandemic. I want to speak very personally because I had 7 family deaths during the 2.5 years or so that the pandemic's been running, including the death of my wife. And I saw firsthand the issues that Kevin and Sandra actually spoke about so passionately from a consumer perspective. And I think we mustn't lose sight of the fact that aside from the dramatic impacts on staff of what they actually experienced during the pandemic and that tale of disease and illness caused by those experiences, both at work and at home, we mustn't forget that NHS staff are actually part of the general population. You're the largest employer in the UK, and that burden of undiagnosed disease, undertreated long-term conditions that actually we talk about as being the challenge of elective recovery actually faces your own staff. And that's why the business case today is actually so much stronger than it was even back in 2009. So as previous speakers have said, there is a need to act, and that need to act is now or never. Thank you, Carol.
Steve, thank you. I don't want to repeat what everybody else has said, but I do want to agree with it. And I want to pick up on Steve's last point of now or never. Steve and I will recall that in 2009, when his review was commissioned after my first review on Working for a Healthier Tomorrow, we really did believe something good would happen Indeed, everybody at the top of the NHS thought it was an extremely good report. Of course, there was a change in government. But if we just have the same response to this excellent report that we had in 2009, we really, really are in trouble. Because what we saw after Steve's report, that there were pockets of extremely good practice. There were places that understood it and did it without really having to be pushed very far. But we know that so much that should have happened didn't happen. We did have a health and wellbeing advisory board on which Steve and I and many other people sat. We tried so hard to get it into the people plan, into the reviews that the NHS were doing. It was a bit like pushing a boulder up the hill. But as Steve has said, COVID, and there are so many awful things about COVID galvanized NHS England an improvement in a way that we must commend. And what they did was to have to cobble together to start to work immensely quickly. And as we've heard, not always effectively, because not everything you put in place is going to be suitable for the staff of the NHS. But let us not forget, they tried extremely hard. And again, Steve and I were involved in that, but we weren't building on sound foundations. We weren't building on appropriate leadership. We weren't building on boards that were engaged. We didn't have wellbeing guardians that were already there standing up for the staff of the NHS. We hadn't got line managers sufficiently trained in people management, these really basic things. And we certainly didn't have the spread and the governance and the regulation to match it. So a response was made in COVID, as good as we could make it at the time. But the situation is pretty clear before us. It can't be made clearer. It could hardly be much worse. And I think our job now is to concentrate on how do we get this thing into practice across the whole system. The business case is there, but it's going to need a lot of people working together to make this possible. We have improved occupational health with Steve's guidance through Growing OH, which he is leading. But again, we need to push that. We need to make sure that this is a service that is really protecting the staff in all its aspects. So can I just congratulate everyone involved, but say, please, please, can we not in 5 years' time be discussing this report in the way we have to discuss Steve's report as a very excellent report that was never put into practice.
Thank you so much, Steve and Carol. We really appreciate you coming along and sharing your business case thoughts on that. I'd like to pass over now to Professor Steve Morris, Rand Professor of Health Services Research at the University of Cambridge, who will discuss the cost analysis response.
Thank you very much, and good morning, everyone. It's very nice to be here talking about this important piece of work. So next slide, please. So just some headline findings on the economic analysis from my point of view. So undoubtedly, the costs of poor health and wellbeing NHS staff are huge, and they're enormous. And the authors estimate a very large figure, as we've heard about already. And I think the authors are to be highly commended for just kind of demonstrating this huge cost. And the other, I suppose, headline finding for me from the report was around how again, as we've heard, there is some evidence about interventions to improve staff health and well-being, but actually more is really needed. So there's a kind of definite call for arms, call for research in this area. Next slide, please. Just some observations and comments from me on some of the details in the report. So one of the really nice things about this bit of work is that the authors look at the costs in 4 different elements. So staff absence, presenteeism, staff turnover, and agency cover. And just a few kind of thoughts on this from me, maybe for discussion later on. So one common approach among economists when measuring staff absence is to use this thing called a friction cost approach, which means that when people are absent from work. That doesn't necessarily result in a lost productivity or 100% lost productivity, because the work is undertaken by colleagues, and that in itself does incur a cost and is important to take into account. The authors have also included the cost of presenteeism, and I see there's been a bit of a discussion about this in the chat already. This is about people working while ill, and I can see that that imposes a very real cost on the individual working while they're ill. I think it's an interesting discussion point about the cost to the service of that, and to try and tease that out a little bit more. The authors also included the cost of staff turnover. This is a real big cost in the NHS, given the recruitment and retention. And I guess the point is quite important to bear in mind is that people might leave their post for a variety of reasons, a lot of which will be due to health and well-being, but not necessarily all. And then there's also a very important cost component that's included in the analysis around the cost of agency cover. And I think that's very important to include. We just need to be mindful about we're not double counting the costs, because some of that might offset the costs of staff absence. I also wondered if, again, from a kind of an economic point of view, whether there were any costs imposed by kind of early mortality on NHS staff, which is a horrendous thing to think about, but might impose a very real cost as well. And then, as we've already heard, I would thoroughly endorse the view based on the findings of this report about more work needed on the value of the interventions. So those are just a few comments and observations from me. Maybe they could form part of the Q&A later on. I suppose despite all of these points, the main point is that the main thing for me is that the costs of poor health and wellbeing of NHS staff are clearly very, very enormous. And I would thoroughly commend the authors of this report for making that point so clearly and so well in their work. Thank you very much.
Thank you very much, Stephen. Fascinating presentation. I'd like to now move on, if I can, to get an NHS response and introduce John Drew, Director of Staff Experience and Engagement at NHS England and NHS Improvement. Thanks for joining us, John.
Thanks, Aidan, and thanks, everyone. I hope you can hear me okay.
Yeah.
Thanks for the opportunity to comment on the report. And we've been working for some time with a number of the people that have already spoken, actually. So it's very much work that we're aware of. I mean, the main messages that I would say are really to reinforce what others have said, that although the pandemic has brought lots of things that we wouldn't have wanted, I think it has, as Carol said, given a fresh focus that's overdue on the importance of caring for our own people, because they're the people that then care for patients and users. So unless we're looking after our own people, they're not going to be equipped, supported, able to give the best of what they can to look after patients. So I think that now means that we have, you could say no excuse, but we've certainly got the focus, additional funding and wider support to understand that health and wellbeing isn't a kind of niche issue. It's fundamental to the delivery of NHS care and how the NHS works. So I think that, as I say, it's overdue, but I think the combination of the people plan and the pandemic itself has really put the focus back on people. The main thing that I would want to communicate that we're doing, and this is very much with the support of the expert advisory group that has been invaluable, which people that you've already heard from, Christian, Kevin, Carol, Steve, and many others have, Neil Greenberg, actually, with his expertise on trauma in the military, have said from a very early stage that the way to improve health and well-being is through a preventive approach that is rooted in organizations and how they function. It's not by offering loads of stuff. So during the early stages of the pandemic, there was lots of additional support that was put in place, which was the right thing to do. But what we've been deliberately doing now for the best part of 2 years is to shift towards prevention. And that is particularly three main areas. So one is really rooting this at board level. Carol talked about the wellbeing guardians. That is a key role that is a bit like the stabilizers on the bike. I mean, ideally, we shouldn't need a wellbeing guardian to do this, but to start with, it's helpful to have a person who's usually going to be a non-exec director who is really advocating for health and wellbeing and the importance of it, and making sure that it's not just discussed when that's an agenda item for the board, but actually it's built into everything else that is on the board's agenda. And I think this type of work and evidence on the business case for particular interventions is going to be really helpful for boards and for Wellbeing Guardians. So that's the first thing, is anchored at the board level in a meaningful way. Second thing, and this is something the expert advisory group have really emphasized to us, is that the thing that will make the biggest difference in the end is feeling supported by the team that you're part of and your line manager. I mean, I've experienced that in my life, and I guess you will have done, that if you're part of a supportive team, all sorts of other things are possible and get easier. Equally, if you're not, then it feels so much harder. And I think we've seen the way teams have rallied round. I mean, I think we heard from Sandra that the pressures that certain parts of the NHS, particularly critical care, were under early on were horrific. I think there's no other word for it. But actually the way those teams support each other, the role of, for example, professional nurse advocates that have been introduced to make sure that people that are already embedded as part of those teams then provide expert help and support to their colleagues, is crucial. So the main intervention there is the role of health and wellbeing conversations. We've been tracking that through the monthly pulse survey, and we know that around 1 million people, so around 2/3 of people in the NHS are having regular health and wellbeing conversations. And we've also put a lot of investment into training line managers to be good at having those conversations, how to be effective, how to pick up on what people are saying. Then the third area is that the evidence and the research said from an early stage that most people will recover and make a good recovery from what they've been through in due course with the right level of support, the kind of things I've already mentioned. But there will always be a proportion that need particular specialist help. So we've been putting that in place through the mental health hubs, which so far around 63,000 people or teams have taken up that offer. So there's a mental health hub in every integrated care system. The strengthening of occupational health, which is a big focus, and we're actually launching the strategy that's been co-developed with the occupational health community on Monday. Steve Borman's role has been really crucial there in taking forward recommendations that he made some years ago. And it would be great to say we acted on it earlier, but all I can say is we're starting from where we are and doing the best possible job that we can. So there's those specialist help, and also the expansion of things like practitioner health, which was originally available to doctors, now to a broader group of people, so that people can get anonymous expert help if they need it. So those are some of the things that we're doing. But there's two other things I just wanted to say. This point that there's no silver bullet. I think whilst it is really important and helpful to understand let's say the economic benefit of individual interventions, the thing that I would not want to back away from is actually, in the end, this is about changing the way whole organizations function and what they prioritize. And that's probably harder to measure in the same way. And in a way, I don't think anyone's arguing this, but it's not just the economic case, it's also the moral case, the human cost that we've heard about. All of that should be causing people to be motivated and to act and make different decisions and different investment decisions on how to get this right. Last thing just to say is that we've been working quite hard to partner with certain parts of the National Health Service that have been under particular pressure and still are. So the three main areas that we've been working with there is actually the critical care community, working with Kevin Fong and others on that, the ambulance trusts and services, who in the staff survey consistently score lower in terms of their experience, and also maternity, which for reasons I won't need to explain are also going through a particularly difficult time. So what we know is that you're more likely to act on and access support that's available if you hear it from somebody that you already know and trust, so a person that you already work with. So that partnership working that Steve Lee, who leads our health and wellbeing team and is on the meeting as well, has been leading on. So those are some of the things that we're doing. We've also got just much better at understanding and measuring this. So I'm really glad to hear people referring to the staff survey. We've strengthened the staff survey this year to align with the elements of the people promise, one of which is we are safe and healthy. We've introduced the 7 questions from the Copenhagen burnout inventory that are the best evidence set of questions about burnout, because we know that that is a risk. and we want to have consistent data on that. This may not be the most exciting note to end on, but there's a thing called the planning guidance that's issued every year to the NHS. It's basically the instructions about the priorities for the year ahead. Before the pandemic, there was usually a mention of what was called workforce, which generally meant the number of people that we have. And that was kind of it. So it might be a paragraph or two. Since the pandemic, it's the opening section of the planning guidance. And in the last couple of years, it's gone on for 3 or 4 pages. And the opening section of that is called looking after our people. So that if that is some kind of measure of the formal description of NHS priorities, I think we should be very positive about the fact that it's actually first on the agenda. The way these documents are written sends all sorts of messages, but I think what comes first is not there by accident. It's very deliberate as a signal. So there are lots of reasons, I would say, to be hopeful about what lies ahead. And I would also just appeal to us to kind of get the right balance between the description of the problem and the level of urgency that we're trying to establish, but also to be quite action-oriented about the solutions, which I think this report is also massively helpful on, because we have to be a little bit careful that we're not talking down the experience of working in the NHS, but focusing on the fact that the problems are now well understood. And as others have said, it's incumbent on us now, and I certainly feel this in my role, to be doing all we can to drive the solutions and the change that we need to see. So I would say that is what we are doing and have been doing now for a decent amount of time, and focusing on keeping the attention on the things I've just described and trying to not get distracted by other things that might come along as, for example, particular interventions, but to keep this focus on trying to shift the way whole organizations work. So I hope that's helpful. I mean, I've done more than just welcome the report. I've also tried to reassure you that the kind of work that is in here and the key messages in the conversation so far are very much informing the work that we're doing, and to thank people for their support, including, as I say, a number of the people we've already heard from who have been helping and informing the work we're doing as we go along. Thank you.
Thank you very much for that, John. That's fantastic. Really great to hear your response on that. I'd like to now hand over to Chris Van Stolk, who is one of our report authors that you heard from earlier. Chris Van Stolk's now going to facilitate a question and answer session. I know some people have been posting some comments in the chat. So if you do have other things, please do add them. There will also be a further opportunity a bit later in the agenda to discuss as well. I'll pass over to Dr. Chris Van Stolk. Thank you.
Well, thanks, Aidan. Also, thanks to John for his reply. Lots of activity in the chat, some comments, really useful comments, and also some questions. I'll start with, I guess, one topic that was asked about quite a bit, and I'll pass perhaps over to Sarah Connolly on this in terms of how we measure presenteeism and how we get to that 6 billion number. And I also saw that Kevin Fong wrote a little bit about in the chat about presenteeism as well. So maybe, Kevin, you want to come in about this as well. So maybe if we start with Sarah and then we come in with Kevin.
Thanks very much. Yes, I think that it's important to recognise the nature of work in the health service. It's mentally demanding, it's physically demanding, and it's emotionally demanding. It was really powerful that what Sandra was talking about in terms of particularly the latter, and so going to work when you don't feel well enough to fulfill all of your duties means that some elements of that are going to suffer. Your performance in some ways will be impaired, and that will be quite clearly, as the comment in the chat, that will have consequences for you individually, but it will also have consequences for others in your team. That if there's one person in a team that isn't working at full throttle, then other people will have to cover, and there'll be consequences there. but also the evidence on presenteeism, studies directly of presenteeism in the health sector also show that there are much greater risks of accidents and of poor patient care. So there are further consequences to the service that can be documented. Kevin, John.
Thank you. So presenteeism is one of these concepts that is difficult to understand. Once you've grasped it, you realize how erosive it truly is, because we're used to looking at who's not there and who is there. But actually, the impairment of the people who are on the shop floor is where you have both the most dangerous losses and, in fact, the ones that cost you the most. Now, presenteeism, as we understand it here, is that phenomenon whereby people continue to turn up to work despite not being fit to do so and not being able to fulfill their full range of professional obligations and duties to the best of their ability. In a separate piece of work that I did, surveying, we surveyed nearly 16,000 intensive care frontline staff across the country at 9 different time points. We found that rates of presenteeism, of functional impairment, and the inability to do your job peaked out at nearly 50% during the COVID pandemic. And even now, in what is partially a recovery, are sitting there at 1 in 3. Now, that should frighten us all, because that is a massive impact to patient safety and the quality of care. And so that is why it is such an invidious and erosive risk, and one that we will only address by intervention at scale. We must, in all of this, and if you take nothing else away from today's report, is we must intervene urgently. We must do so with sufficient scale and ambition. The alternatives are much worse. Thank you.
Thank you, Sarah and Kevin. That's really, really useful. Lots of discussion in the chat as well around burnout and also post-traumatic stress. And perhaps a question that's underlying all of this is, well, how do these practices deal with burnout and post-traumatic stress? So the practices that we reviewed in this review. So maybe I'll hand over to Kevin, and maybe Sarah, you want to come in on this as well. Another question I think came from Chris Hewitt around, oh no, sorry, I think it might have been Penelope Crane, about clinical psychologists and why there weren't any clinical psychologists who were involved in this review. So maybe Kevin, also something that you can talk about, and maybe Kevin, you want to come in, Kevin Fong, you want to come in on as well.
So with respect to the post-traumatic stress, I think there's a few things there. The figures that we've seen in the evidence used in this review are impossible to ignore. The rates of post-traumatic stress are comparable to or in excess of that seen in British military veterans who are deployed in Afghanistan in a combat role. It's quite a convoluted sentence, but when you swallow it down for what it is, it's simply terrifying. However, it's important, as I've been reminded often, not to get distracted only by that phenomenon. We saw screaming high rates of anxiety, depression, harmful use of alcohol. And again, that this is not just COVID. It's very clear from the work of Steve Borman and others going back many years that this predates the pandemic. And so again, the best way to avoid these things is to provide a foundation that prevents these the scale of these injuries occurring in the first place. So I think that I think it's important to put the post-traumatic stress work in that context. Yes, this is part, but it is again, and for me at least, it's one of the clearest illuminating factors. It is the whole piece, and is the need for us to intervene, not just post hoc, to prepare ourselves for whatever lies in the future, next pandemic or otherwise. We are going to have a workforce and a health service that is in better shape than it is currently. Thank you.
And Sarah, Kevin Daniels, what about the evidence base around what these practices do for stress in the workplace, burnouts, post-traumatic stress? I guess my sort of assumption would be that there is relatively little in the literature on that, or am I mistaken?
I mean, I think it's just interesting. So, for the clinical psychologists in the audience, I'm an occupational psychologist, not a clinical psychologist, so I made that clear, fellow of the British Psychological Society. But there's quite a lot of evidence for, you know, kind of talking therapies do work, but they are after the fact. After harm's occurred. Now, if you look at the guidance, my background's in health and safety systems, as you know, Chris, if you look at the guidance, and you need the health and safety system, which focuses on how work is managed, but also inevitably people will get ill for whatever reason, have life events outside of work, and you need to have in place care facilities for those people that do get ill for whatever reason. So, the recommendations here, ISO, NICE, whatever, they all recommend, you do the primary prevention, as kind of public health language. So you look at how the organisation's managed and you optimise that. You do the secondary prevention, which is self-care, and you do the tertiary prevention, which is basically rehab and the treatments that go along with that. And that should all form part of an integrated and strategic managed coherent system. The kind that John Drew was talking about, kind of the aspirations for the NHS. So you have multiple interacting elements, all addressing different parts of the problem. But as Kevin Fong has just said, don't wait. You can't just leave it until it's too late. So you do have to do multiple things. And we've used the phrase, haven't we? There's no silver bullet. It has to be a whole systemic, cultural, and managed approach.
Yeah, and I think that the other thing is that we haven't even touched upon some of the opportunity costs. If actually teams, trusts, hospitals are so busy firefighting, managing staff shortages, managing staff turnover, trying to recruit to unfilled vacancies, they can't focus on other strategic goals. And so it makes it difficult to run the service that you want to run, that you think that ought to be run, because you're so busy firefighting on a day-to-day basis.
Great. I think John Drew wants to come in on this as well.
Yeah, I just want to acknowledge the link really to staffing numbers, because the staff survey last year, one of the most striking questions or responses was about asking people if they feel they have enough people to do the work. And there was an 11 percentage point drop in the answer to that question. And I've put in the chat box, but that's in spite of the fact that there are nearly 100,000 more people working in the NHS than 2 years ago. And I think most people would look in surprise and say, well, it really doesn't feel that way. And it doesn't. But part of the reason for that is that there's been a lot of disruption to the way care is normally delivered and teams work during the course of the pandemic. I mean, an obvious example of that would be infection prevention and control. So there's actually been a piece of work done to look at this, showing that the drop in productivity because of that and other reasons is greater than the increase in the workforce has been. But what that does mean is that as we settle into new rhythms of work, we should see the effect of those additional people. It's also true, as others have said, that there's still a significant vacancy gap, because essentially the demand for healthcare is always rising. And I think we just have to be a bit realistic about that. That's certainly all developed health systems. And we've got a 3-year funding settlement for the NHS now that we're going to have to live within. So we have to find ways of making the best use of the people and the skills that we already have, as well as recruiting more. And I would say that that's also a significant source of learning from the pandemic, is that trying to move towards specifying what needs to be done, but not being too prescriptive about how, so that teams can come up with improvements to the way care is delivered locally. And there are opportunities through significant investment going into things like community diagnostic centres, elective hubs, to actually come up with better ways of working that are better for patients, simpler for staff, and also more productive. So we're very much not, and I'm under no illusion, in fact, I'm leading on the workforce aspects of elective recovery. We can't treat health and wellbeing in isolation. we have to consider all aspects of the people plan, which is more people working differently in a compassionate and inclusive culture. So I just want people to know that we do see the bigger picture and the need to connect these things.
Thank you, John. And before we go over to Kevin Fong, Steve Lee also put some useful information on the chat, picking up on some of Kevin Daniels' points about primary, secondary, and tertiary interventions. Kevin, you want to come in on this, Kevin Fong?
Just very briefly, and it's absolutely agree with John there about the primacy of workforce and the workforce challenges, which are also formidable. However, I would say that workforce shortages seem to be a primary cause of much of the well-being problem. It's very, very clear that that is the case. This picture I paint of stretching the staff more thinly into the gap, and the comment earlier about how if the productivity continues, then no one really measures the cost of that, but the cost is clearly being felt at the level of well-being here. And the other thing that we always say is that there's two other things. One is we're losing quality as well as quantity. So it's excellent what we've done to recruit more staff, but when you're losing people with the quality and length of experience of someone like Sandra Barrington, and we are losing those people at the moment, then that's a very difficult cost to measure, but it's huge operationally to us. And then finally, the solution, one of the things that this report has made me sort of take a better view of and understand is that we talk often about inefficiencies in the workforce, and indeed, I think the NHS is inefficient, but not in the way that we usually accept. It is inefficient over its use of human resource. One in 4 nurses leaves the profession within 3 years of starting it. Our retention is worse than most other comparable industries. And so in terms of wanting more bodies on the pitch for the coming years, the best way to immediately solve that is reduce the retention problem. And that is a well-being issue. And so there is an absolute need for investment now. We can't just be working smarter. It's not going to work. Thank you.
Thanks, Kevin. Now over to the other Kevin. Kevin Daniels has his hand up. Do you want to come in on this, Kevin?
Yeah, I just sort of pick up on the point John made about basically local adaptations, contextual adaptations, because there isn't one size fits all. There isn't a silver bullet. Things do have to be adapted according to the local context, and what might be appropriate in Stoke wouldn't be appropriate in Norfolk, for example. So I think what John said underscores the need for this continual adaptation. Yeah, sure, learn from other locations, do swap knowledge, and that's really important to get that kind of shared learning across the whole service. But also, do recognise that things will be done differently in other locations, and we see this in other sectors. We see it in multinationals, we see it, in construction companies with different sites who do things slightly differently. But the key thing there is to engage people in a conversation. So, about what is appropriate for that particular circumstance, that particular context, and adapt. Context changes, circumstances change, so it's a continually adaptive process. It's not a kind of, well, we've done that now, we can forget about it. You can't. You have to embed it. So having, the symbolic importance of being well-being on the first of the agenda, for example, that really does send a clear signal that it's not a one-off. It's a continually evolving process that needs to be worked at.
Thank you, Kevin. Sarah, you have your hand up. You want to come in on this point?
Yes, please. I was just going to say, I think this is why the establishment of the Wellbeing Guardians that were described earlier, that's really important, because that gives both a forum for sharing experience and the platform for the trust level discussions, but also Sian in the chat mentioned hubs of wellbeing, and I think that this sort of sharing of experience, sharing the evidence base is also, and perhaps how local variants have been discovered and implemented, really very important mechanisms.
Great. A couple of questions in the chat that I wanted to pick up, and probably for Kevin Daniels. The question about evidence around wider systemic changes, cultural changes versus these interventions. I think that was a question that Jenny posed in the chat. I thought it was quite an interesting one. And also a question, I think, from Joanne around understanding really not just the evidence-based of interventions, but also how they work in different contexts. I think is a point you made in your presentation, Kevin. So if you maybe want to reflect on both of those.
Yeah, I mean, without getting too technical on the kind of like the social science behind some of this, this is an NHS audience, so like, you'll all be familiar with randomized control trials, and it's easier to do a randomized control trial with something like mindfulness, or some sort of therapy than it is with wide-scale systemic change. It's cheaper, it's easier to randomize people, etc. So I think if you look at cultural systemic change, you need to use other methods, which are usually more qualitative, more in depth. So you see you're tracking an organisation over time. Now within that, you can do the evaluations of these smaller initiatives that go into making up your culture change. So a culture doesn't change by, I don't know, someone making a speech or something like that. It's about changing patterns of behaviour. So you need lots and lots of initiatives in that wider systemic change, and you do the evaluations on those in the more or less, controlled a way as you can, using sort of questionnaire measurements and those kinds of things. But the wider systemic change, then, if you're researching it, then you need people kind of embedded and seeing what happens and how things evolve and adapt. I think the other thing in there is you find I'm familiar with some work that was done at Loughborough on Tideway, the big thing in the big tunnel there, boring under the Thames. So the Loughborough safety researchers were kind of looking at how the safety culture evolved through the adaptation of different practices, and how some things were stopped and other things were started because they weren't working, and that's so that's an exemplary approach. It is from the safety area, but kind of looking at those wider scale things and then saying, well, what is it about this specific context that might transfer or wouldn't transfer? So it's using different research methodologies and different expertise within that, but certainly do the kind of standard evaluations for initiatives, because what you don't want to do is embark on a great big culture change initiative and then you start putting in places for which there is no evidence and no evaluation, and you do need to do the evaluation to get the adaptation anyway.
Well, thank you, Kevin.
Answer people's questions.
I think so. I mean, there's lots of interesting comments going on in the chat as well. Lots of interesting resources that people are signposting, and thank you so much for doing that. There's some further questions. Hopefully, we might be able to get to those a little bit later on. But I'm going to hand back to Aidan in the meantime, so we can introduce our next speaker.
Thank you very much, Chris. And as Chris has said, there is some further time on the agenda for us to continue this conversation. So please do feel free to add more comments in the chat if you would like. We'll now hear from Rebecca Williams, Associate Research Fellow at the University College London, who will share with us the research that she's doing as part of her PhD on improving staff wellbeing. Rebecca's also a nurse, has worked on the front line during the pandemic. I'll pass over to Rebecca now. Thank you.
Hi, thanks so much. Just want to check everyone can hear me okay. I'm gonna assume yes, thank you. So I just want to start with my thanks, both for the opportunity to respond, but also for this much needed review. The critical necessity of investment into NHS staff has become increasingly apparent in both my work as a bedside nurse, but also my research into care distribution. The call put out in this review for financing of staff welfare research and services is vitally important, and one that cannot be ignored if we want to ensure that the NHS is still here in years to come. What I want to address in my response today is barriers to achieving better staff well-being. So whilst the report makes a clear business case for investment, demonstrating that better staff well-being does lead to better trust performance outcomes, it's also making a moral case, as behind the data sets are humans, and these are humans who are suffering either as staff or as their affected patients and their impacted families. It's these experiences that make up the heart of my PhD thesis, which focuses on how ward staff ration the care they give. Care rationing is often discussed as an outcome of limited resources, but my resource demonstrates that it's actually an inherent quality of caregiving, and it's also part of the laws of physics. That as a carer, I can only attend to one patient's needs at a time. Thus, all my time, attention, and energy, which makes up the very basics of care, must be divided up between patients. And whilst we endeavour to do this justly, and my research shows that healthcare staff really work hard to do this justly, patients and tasks must be prioritised. On the ward, this meant deciding which call bell to answer first, what order to do medications rounds in, whether to spend 5 minutes cleaning someone's teeth or taking someone else's bloods, or who to attend first to change soiled sheets. If this is the starting point for care, I'm sure you can imagine what short staffing might mean. It means call bells unanswered, delayed medication, teeth unbrushed, and someone being left in filth and indignity. Staff miss breaks and go home hours late to try and mitigate the impact of limited resources in the face of seemingly limitless need. And this isn't rare, it's actually, in fact, the norm. For example, on the ward I did my research on any given day, you are likely to find day staff nurses updating their patients' notes gone 9 o'clock at night. So that's 45 minutes after their shift has ended. And they were told on this ward that overtime couldn't be claimed for late leaving if it involved delivering patient care, which was completely dismissive of the fact that they chose to delay writing their notes in order to prioritise patient care. How long can someone continue to work beyond their capacity before they break? I think we're beginning to find out, and this report shows the costs of this. In an already physically and emotionally laborious job, the moral injury to staff caused by care rationing is an additional and significant cause of burnout. Sometimes this burnout is measurable in the form of absenteeism, clinical mental health disorders, and falling staffing levels, but it's also impacting patient outcomes in quieter and more insidious ways via compassion fatigue. Staying late shift after shift and not being recognised for the work you do out of hours means eventually you stop working out of hours. You start making sure your notes are completed before the next shift starts. And making time for this means taking time from elsewhere. So maybe you won't make that patient a drink or assist your colleague, organise a discharge, or mobilise someone to the bathroom. You make sure that you take your breaks on time, you don't spend any unnecessary time getting to know patients, and you roll your eyes at additional requests. I've heard this isn't the Ritz on more than one occasion. This is what's happening when people are turning up to work and doing the necessities, but are also trying to protect themselves. Patients suffer for it. Management is not blind to this. They're very aware it's happening. And they stress staff-patient ratios as far as they dare, but they do have to draw the line somewhere, which leads to scenes like the one you can see on your screen, closed beds. On my ward, closed beds during the pandemic meant cancelled surgery, delayed chemo and radiotherapy, and limited emergency admissions. The business case put forward by this report demonstrates the financial impact of absenteeism and presenteeism on the NHS. My research speaks to the human cost. As part of my analysis, I look at the value frameworks utilised in decisions about who is prioritised for care, where time and energy is spent. And I want to use the next couple of minutes to apply this thinking to addressing turning report outcomes into actions. So we know that services were running at capacity pre-pandemic, and that NHS staff have had to shoulder the burden for an overloaded system. My hospital trust was lucky enough to have a dedicated staff experience team who did their utmost to support healthcare staff during the pandemic. They created rest spaces, delivered hot meals, provided wellbeing and mental health support. They are knowledgeable to the cost and impact of poor staff experience and implemented as many of the strategies highlighted in the report as they could. But these were completely underutilised by ward staff. I'm currently working on a scoping study alongside members of the team behind this review, looking into barriers ward staff experience in accessing existing wellbeing support. It's in early days, but it really indicates so far that job roles, work environment, and patient allocation are the main reasons staff are unable to access both existing services and information about the services. And it's the demands of the job, a job that constantly prioritizes patient care, and rightly so, that is stopping them from being able to look after themselves. So this makes the report's key findings that the biggest improvements to staff wellbeing were being made via systemic and cultural change almost unsurprising. It's because all the other stuff was dealing with the symptoms rather than the disease. So if hot meals and yoga won't cut it, we need to start looking at what the job entails and think about how we might rework basic working structures to ensure carers' welfare is prioritized. And what will that take? Well, serious investment is a good start. And if we're all in agreement that the moral and business case align, what's stopping that? Here, I'm moving from empirical research to my own experience-based opinion to argue that we will not be able to move forward until our values are aligned. On the surface, it appears they are, but there are serious conflicts of interest between existing welfare and political systems. This is mostly an ideological one. The NHS is idealized as a symbol of a responsible nation state servicing its population and looking after the vulnerable. And this is a dangerous political tool. It allows politicians to use its branding for their own political claim. They can make claims of upholding the public's right to healthcare via its free at point of view services, while systematically dismantling it and underfunding it from within. This is the result of the UK's healthcare and political systems operating on very different timeframes. The NHS holds to the same ideals it was founded on 75 years ago and works to ensure healthy futures for the population. Politicians are trying to secure the next 5 years in power. This leads to the repeated minimum repeated minimum investment for short-term win. Hot meals and yoga are short-term wins, but they are all that can be realistically delivered within the current levels of investment. In order to meet the ideal of what was just said, more people working differently, for example, I would argue that beyond additional research into barriers to bettering staff well-being, an additional case needs to be made. We know the moral case, and you've delivered the business case brilliantly. And now I think we need to make a political case to demonstrate that long-term improvement into staff experience is absolutely vital for the running of this country in order to ensure the future of the NHS. Thank you very much.
Fantastic. Thank you so much, Rebecca. That was really, really interesting to hear your perspective on that. Thank you so much. We are coming very close to the end of our session this morning. What I would like to do is go back to Dr. Chris van Stolk for more of an open discussion with the audience. Perhaps people have questions for any of the speakers that have spoken today. So I'll pass back over to Chris to facilitate that session. Thanks, Chris.
Yeah, thanks, Aidan. Lots of stuff going on in the chat. Obviously, some really, really good stuff. Also, thank you to Jill Mabin for posting a number of resources in there. Some really good discussions, I think, around burnout. Some really good points being made, some resources, also some studies taking place. Thank you for the person in Belfast with that link. Lots of interesting things happening there. So this is a chance for you to ask any additional questions. I know there is one question, I think, on the chat, and also you can raise those directly with the panel if you want to. One question around how we can improve access for staff to health and wellbeing programs or interventions. I was just wondering if Steve Borman was still on the line, and whether, Steve, you want to comment a little bit about the Occupational Health Initiative and also how to improve access to that. I mean, I thought that there was a clear overlap with your thinking in terms of how we make services more available to staff, and also, I guess, make it more convenient for staff to access those services.
Thanks, Chris. I think there are two aspects to this. There's the improving the access to better services, which is what growing occupational health and wellbeing is all about, in terms of changing the reputation, changing the focus to actually be seen as a trusted part of prevention and protection, rather than somewhere that you get sent to when there is a problem. But the other aspect actually is about changing the way staff think themselves. And they often forget that actually most of the professions in healthcare are regulated, and they have a duty of care to their patients to actually be well in the first place. And it's a bit like fitting your own oxygen mask first. The culture in the NHS has been about soldiering on and putting up with actually how you felt. Whereas actually what we need to do is actually change the way in which staff perceive their health, so that they actively seek and ask for help when they need it, rather than actually wait for there to be a problem. Thanks.
Thanks, Steve. And while I have you here, I mean, you reflected a little bit on the lessons that came out of your review in 2009, how things had not moved forward. And so in terms of the smoke signals you're seeing now, and we of course heard from John before, and I think Steve Lee is still on the line. In terms of where you see things moving at the moment, do you see like a step change happening? Do you see like us moving in the right direction? And what will that change look like? I guess it's a difficult question, I know, yeah, but maybe of interest.
Again, I think it's a glass half full and a glass half empty answer. So the glass half full is that for the first time in 15 years, I'm actually seeing momentum. I'm seeing change. I'm seeing people like John and his team and others on this call really stepping up to the plate and taking this seriously, and using, perhaps it's the wrong way of saying it, but using the crisis of the pandemic and the political attention that is on actually the health service at the moment as the opportunity to actually force some of these things through. But the glass half empty bit is reflected again in some of the chat that we've seen, is that NHS staff have been through so much, and this is the point at which actually people start to think, actually, is it time to change my career and step away? And they're cynical about actually whether this is the point at which change will really happen. And that's why we're losing, particularly amongst nursing staff, very experienced and very senior nurses at this point, because we've stretched them to the limit and we've told them before that we were going to make life better, but actually we didn't do it. So that's why I think it's now or never.
Thank you, Steve. That's really, really useful. We have Sandra with her hand up as well, and I would like to bring Sandra back at this point.
Yeah, so I think a couple of things for me. I agree with everything that Rebecca said, and I think, you know, in when I described my experience, it was based around the pandemic, but I also have a corporate role, and what I know that out there we have a crisis. So there is very few areas that have what I would say is optimal staffing. So we're on the very minimal safe staffing levels, if you can put safe in there. And what we know is that when somebody rings in late and goes off sick, there is nobody to backfill them. And sometimes you're making decisions about which ward are you going to leave the least unsafe when you're moving staff around. And I think, as Rebecca said, staff stay late to do their notes. I know when there's staff not coming on a night shift, people will stay into the night to try and help out their colleagues. And I think one of the biggest barriers to accessing wellbeing is that a lot of the resources that have been offered to staff are online, and the only time that they have to access them is when they go home. And when they go home, the last thing they want to do is start to access something that reminds them of work. They want to switch off, and I think that's really, really difficult. The other thing, if I could just mention, John talked about professional nurse advocates supporting the workforce, and this was very welcomed within our organisation, and I've actually completed the P&A training myself. But what I found at the time when I worked with other nurses completing the training, and since in my own organisation, is that although there's been this significant investment in P&As being trained throughout the country, actually these are frontline staff who are not being given the time to work in that capacity. So it's fine giving people the training to be able to support the wellbeing and the restorative supervision, clinical supervision within the workplace. But actually, if you're not going to build that into your workforce budget, these staff do not have the time to do it. And so I think we need to be very careful when we're looking at spending lots and lots of money on wellbeing, which is absolutely needed, that actually we know that the benefits or of the intentions are actually are received and are felt. There just doesn't seem to be that full cycle in terms of, you know, we've given all this money, we want trusts to invest in wellbeing, here's pots and pots of money, but actually the staff that need it can't access it. And as I say, people are being trained to deliver these support, but actually not given the time to do it. And I've just seen something in the chat, which it's that vicious cycle that at some point we have to break. And I think the other final point really is this. I absolutely agree that we should not be prescriptive in terms of what people do in their own areas, because every region and area is different and has a different experience. But I think you're also in danger then of having inequality across the country. So what I saw when I went out with Professor Fong was that there were some really good initiatives and wellbeing that was reaching certain staff that wasn't in other organisations. And unless you break this cycle of the investment and what you're getting back from it, you're going to have this inequality.
Thanks, Sandra. And maybe Carol, if you're still there, I know you are. I wanted to bring you in on exactly that point about the relationship between top down and bottom up. And I know we're getting to the end of the session, so maybe we can, and I see that Kevin has his hand up as well. But Carol, you know, this question about how much of this is top down and how much of this is going to be bottom up, and what is the role for people taking their own initiative, and then of course taking into account the issue that Sandra raised around inequity. So maybe, I don't know if you want to reflect on that, and I'll bring in the two Kevins as well.
I do think it's both, Chris. I don't think it's one or the other. But it was interesting listening to the discussion. It's almost as if, yes, there are these things that are available for the staff, but either the staff feel there's no time or even maybe permission to really go and invest and take part in them. So we have a real problem that if we're improving what is available in terms of interventions, and I accept that we still need more research on all of this, but how do we ensure that people can access them at a time that is convenient and appropriate for them? I mean, it is ridiculous to go home and then have to switch on your machine to access what's online. I mean, that is not the way it should be. But they feel so much that they've got to look after the patient that they can't take any time to look after themselves unless, yes, just as Kevin said right at the beginning, if you don't really invest in the staff, then you won't get better patient care. Those two things are so intimately related. So we could do a lot of work creating all kinds of nice interventions. But if we haven't got the right organizational approach to making them available and encouraging people to take part in them, I mean, we're just providing more things, but no real improvement. And how much of that is, as Kevin has said early on, that's Kevin Fong, due to needing more staff to do the things so that people have more time to invest in themselves. I mean, I think some of that is coming out in the discussion, you know, and how do we get that balanced out, that staff feel it's there for them, there's time and energy, and it's appropriate to their needs. So I think we haven't bottomed that one out at all.
Thank you, Carol. Just Kevin Fong, Kevin Daniels, if I can ask you to be brief. We're sort of getting to the close of the session, and then I want to go to Carol for a final summary before handing back to Aidan. I also see that Caroline has her hand up as well, so maybe Kevin Fong and Kevin Daniels, you can be brief on this.
So I'll be as brief as I can. So with regard to top down and bottom up, I don't think it's either or. I think it's both, but different in style. COVID presents an illumination of the problem, but it also suggests the solution. During COVID, when we had to rapidly change to meet an urgent need, we had a facilitative top-down approach. The top facilitated frontline solutions because people in Sandra's position at shop floor level are best placed to understand solutions. Now, on top of that, as Sandra alludes to, we then need to invent proper mechanisms for sharing best practice. That's the way forwards. You cannot drop solutions on people from 36,000 feet and then wonder why they're not intact when they hit the ground. Thank you.
Thanks, Kevin Fong. Kevin Daniels.
I'll talk about the inequalities and standardization very briefly, but on the time thing, one of the interventions we looked at was related to management development, and the reason why it didn't work was no one had time to turn up to learn how to do the management development, be a better manager, which speaks to Sandra's point. On the kind of standardization and inequalities and tailoring, with the research that we've been doing, and you know about this, Chris, because you've been involved in this research, is there's a continually, organizations have to manage this tension between a standardized process, which is for everybody, and something that's contextually specific, which is tailored and useful in a particular location. So it is a balancing act, and it goes back to this idea about having a managed program. It's an ongoing process, so there'll always be this kind of seesaw going on, and we see this in other organizations. And it's just part of the tensions of managing a wellbeing program. So it's there, and it's something that has to be managed.
Thanks, Kevin. Caroline, a quick point from you, if you can keep it really brief.
Yeah, really, really brief. I just wanted to say this is so important because it really has an impact on students, on professional programs as well in practice, and that also impacts on tutors that are supporting students.
Thank you. I think the education element is really, really interesting in all of this as well. And Carol, over to you maybe for some final thoughts, and then we'll hand it over back to Aidan.
I'll be brief, Chris. I think this has been a really good session. I think everybody here feels that this report is timely and needed, but I want to stress we're talking to the converted. We all here know this. What I really want to know is how do we now put into action your recommendations? Because it's all very well, we've had an excellent discussion. We know that things need to be done, but these things are still on paper, Chris. So your high level interventions, what is the journey now? What is going to happen? How are we going to follow up? How are we going to make sure that change happens? John said, we've now got no excuse, John Drew. I mean, he said quite clearly, it's not a nice to have, it has to be embedded. But we said this quite frankly in 2009. So what are we going to do, either collectively or through different organizations, not to let this report sit on the shelf? Because all of us, we may want to do it in different ways, but there's no disagreement. But it can't just be, another very good report. It is an urgent issue, as Kevin said right at the beginning.
Thank you, Carol. Very inspiring.
Thank you very much, Carol, and thank you very much, everyone, for attending today's event. It's been really a great opportunity to get everyone here. I just want to say in the final few minutes a thank you to all our speakers, Dr. Kevin Fong, Sandra Barrington, Kevin Daniels, Sarah Connolly, Dr. Chris Van Stolk, Dr. Steve Borman, CBE, Professor Dame Carol Black, Steve Morris, John Drew, Rebecca Williams. Thanks so much for attending today. There'll be a link in the chat in a moment that will take you to our rapid evidence review, which you can access on our website. If anyone does have any questions about this event or the rapid evidence review, please do get in touch with us at ippo@ucl.ac.uk. Once again, thank you so much for joining us and have a pleasant day. Thank you.